Hello and welcome back to another edition of The Deep Dive.
Hello?
Today we are shifting gears. We aren't analyzing a news article or a viral trend.
No.
We are going to tackle a giant. We are opening up the Bible of surgery for a huge portion of the English-speaking medical world, Baily and Love's short practice of surgery.
That's a big one.
And we are zooming in laser-focused on Chapter 58, the breast.
It is a massive topic. And frankly, for anyone in the medical field, I mean, whether you're a medical student sweating over finals, a surgical aspirant prepping for the boards, or just a clinician trying to stay sharp, this chapter is the absolute bread and butter. You really cannot walk into a surgical exam, let alone a clinic, without having a firm, confident handle on this material.
Exactly. But here is our mission for today. We are not just going to read the textbook to you.
God, no.
That would be incredibly boring, and frankly, you can do that yourself. Instead, we are going to be your study partners. We've gone through Chapter 58 of the 28th edition with a fine-tooth comb. We've pulled out the key concepts, the hidden gems, and the exam traps, and we want to create a ready reckoner.
I like that term, a ready reckoner.
Right. We want to move you from rote memorization, just, memorizing lists of lymph nodes, to actually understanding the concepts so they stick.
So they stick when you're standing at the patient's bedside at 3 a.m.
That's the moment.
That's the key, conceptual understanding. But we have to start with a disclaimer, as always.
We do.
We are synthesizing and interpreting the source material to help you revise and understand. We are not the textbook itself.
Absolutely not.
If you want the absolute source truth for your exams, or if you're making a clinical decision, you need to open Baily and Love and read the words on the page.
Think of this deep dive as the scaffolding to hang that knowledge on.
Exactly. We're the primer before the paint.
I like that. So let's map out the territory. We have a lot of ground to cover.
We do.
We're going to start with the landscape surgical anatomy and assessment.
The lay of the land.
Then we'll move into the benign stuff, using a concept called ANDI and the seasons of the breast, which is a really fascinating way to look at it.
It really is a game changer, that concept.
We'll look at inflammation, infections, and then we tackle the big one, malignancy.
Risks, pathology, staging. The works.
The works. And finally, we'll wrap up with the arsenal management, from the scalpel to the biology.
It's a logical flow, from the structure to the problems to the solutions.
So let's start at the beginning, the anatomy. But let's not just list borders like we're reading a grocery list.
Please don't.
Let's talk about the engine room. In the text, they really emphasize the TDLU.
Right, the TDLU, the terminal ductal lobular unit. If you want a mental anchor for breast pathology, this is it. This is your ground zero.
Okay.
It's easy to think of the breast as just a mass of fat and connective tissue, but the TDLU is the functional unit.
It's the bit that does the work.
It's the bit that does the work. Think of it as the factory floor. You have the terminal ductual and the lobule together. This isn't just static tissue. It's incredibly dynamic. It is the most active part of the breast.
And it's not working in isolation. It's
it's
listening. Right.
Exactly. It's constantly listening to the hormonal environment. It has receptors for estrogen, progesterone, prolactin, growth hormone.
Wow.
It shifts and changes based on the menstrual cycle, pregnancy, lactation, and menopause. And the text makes a specific point that most breast diseases, both benign and malignant, arise right here in this unit.
So when we talk about pathology later, we are essentially talking about something going wrong on that factory floor.
Precisely. It's where the action is and consequently where the trouble usually starts.
Oh, okay.
Now, surgically, we need to know where this organ actually sits on the chest wall.
The geography. So Baily and Love defines the boundaries pretty clearly. Vertically, we're looking at the 2nd to the 6th rib. Horizontally, sternum to the mid-axillary line. That seems straightforward. But there is a trap here for the unwary examiner, isn't there?
Oh, a huge one.
The tail.
The axillary tail of Spence. Yes.
Huh?
This is a crucial bit of anatomy that trips people up all the time.
All the time.
It's breast tissue that extends laterally and upwards into the axilla. It actually pierces the deep fascia and enters the axilla proper.
Right.
The reason this is a critical clinical detail and why it's highlighted in the text is that it could be palpable. It feels like a mass in the armpit.
And if you don't know your anatomy, or if you're a junior doctor feeling around in a rush, what do you mistake it for?
You might think it's an enlarged lymph node or maybe a lipoma.
Sure.
But it's actually normal breast tissue. And because breast tissue, it swells premenstrually or during lactation, just like the rest of the breast.
Ah, so that's a key clue.
It's a huge clue. Knowing that tail exists prevents you from misdiagnosing a mass in the armpit Or, even worse, missing a breast cancer that is hiding way up there because you didn't check high enough.
Let's talk about the support structure, the suspensory ligaments of Cooper. I always visualize these like the cables on a suspension bridge holding everything up.
That's a perfect visual. It's exactly what they do. They are fibrous bands that run through the breast tissue, attaching the dermis, the skin, down to the pectoral fascia, deep inside. They give the breast its shape and lift. But the clinical relevance here is huge.
It's responsible for one of the most important signs in a physical exam.
It is. Because of what happens when a tumor meets a ligament.
Right.
If a cancer grows and infiltrates these ligaments, the cancer cells cause a fibrotic reaction. They make the ligaments contract and shorten.
And since they are attached to the skin?
It pulls the skin in. Exactly. That causes dimpling. If you ask a patient to lift their arms or contract their pecs and you see a dimple appear, you are seeing the physical effect of a tumor pulling on Cooper's ligaments.
It's a sinister sign.
It's a very sinister sign, and it's pure mechanics.
Okay, let's move to the drainage system, the lymphatics. The text says 85% of the lymph drains to the axilla. This is the highway for metastasis.
Which is why the axilla is almost as important as the breast itself in cancer surgery. But to understand the axilla, you need a landmark, a gatekeeper.
Okay.
If you are looking at an anatomy diagram in Baily and Love, your eyes should go straight to the pectoralis minor muscle.
Everything is defined in relation to that muscle, right? It's the anchor.
Correct. It is the anchor. We divide the lymph nodes into 3 levels based on where they sit relative to the pectoralis minor.
Okay, let's break that down.
Level I nodes. They are below and lateral to the muscle. This is usually the first stop for drainage.
Right, the outer edge.
Level 2 nodes. They are behind the muscle. This includes Rodder's nodes, the interpectoral ones.
Okay.
Level 3 nodes. They are above and medial to the muscle, essentially at the apex of the axilla.
So it goes from outside in, lateral is level 1, behind is level 2, medial and above is level 3.
Precisely. And clinically, that matters because it dictates the extent of disease. A cancer that has reached level 3 is much more advanced than one contained in level 1.
And it dictates the surgery.
It absolutely dictates how extensive a lymph node clearance might need to be if you're operating.
Before we treat anything, we have to diagnose it. Baily and Love talks about the triple assessment.
Sure.
This is the gold standard.
This is non-negotiable.
It feels like in every medical text, there's a triad or a rule of 3, but this one seems foundational.
You cannot skip a step here. It's a stool with 3 legs. If you remove one leg, the diagnosis falls over.
So leg 1.
Leg 1 is clinical, history and examination. What do you feel? What is the patient telling you?
Leg 2.
Imaging.
And leg 3.
Pathology, a piece of tissue.
Right.
The text states that when all 3 of these agree, say the clinician feels a hard lump, the mammogram sees a spiky mass, and the biopsy shows cancer, the diagnostic accuracy is 99.9%.
That is incredibly high. It's basically as good as it gets in medicine.
You can take that to the bank.
But let's unpack the imaging leg because it's not one size fits all.
No.
We have ultrasound and we have mammography. How do you choose? Can't we just X-ray everyone?
You can't. And it's largely about density and age.
Okay.
Younger women, usually defined as under 35 or 40, have very dense glandular breast tissue. If you take an X-ray, which is a mammogram of dense tissue, it just looks white. And cancer also looks white.
So it's like looking for a snowball in a blizzard.
Exactly. It's a whiteout.
Yeah.
So for the younger demographic, mammography is essentially blind.
It misses things.
Often, yes.
Yeah.
So for younger women, ultrasound is the primary modality. Ultrasound uses sound waves, so density is an issue. It's also fantastic for telling if a lump is solid or cystic, meaning fluid-filled.
And mammography is for older women where the breast has started to involute and become fattier?
Generally, yes.
Yeah.
Fat appears dark or gray on an X-ray, so the white cancer stands out clearly. It becomes the first-line investigation.
And when you get a report back from the radiologist, it comes with a score? The BIR test score?
Yes, ranges from 0 to 6.
We should quickly run through those because for a listener looking at a report or a student in an exam, these numbers are high yield.
Sure. It's a risk stratification. BIRADS 0 means incomplete. We need more views. Something isn't clear.
Okay.
BIRADS 1 is negative, normal breast.
Good news.
BIRADS 2 is benign. This covers things like a simple cyst or a calcified fibroadenoma. No worry at all.
Right.
BIRADS 3 is probably benign, less than 2% chance of cancer, but you want a short-term follow-up just to be safe.
Keep an eye on it.
Exactly.
Yeah.
Now, BIRADS 4 is suspicious. The risk jumps significantly. You need a biopsy.
Okay, this is where it gets serious.
It does. BRADS 5 is highly suggestive of malignancy, over 95% chance.
Wow.
And BRADS 6 is, you already know it's cancer, it's biopsy proven, and you're maybe doing the scan for staging.
So 4 and 5 are the ones where the alarm bells are ringing loud.
Very loud.
What about MRI? The text mentions it's a valuable adjunctive tool, but we don't scan everyone with MRI.
No, it's too sensitive. You'd get too many false positives. And it's expensive. It's a problem-solving tool.
So when do you use it?
You use it for women with implants because mammograms can't see around the silicone easily. You use it for women with extremely dense breasts where other imaging is equivocal. You use it for high-risk genetic screening like BRCA carriers because you want to catch things when they are tiny. And importantly, if you are giving chemotherapy before surgery, you use MRI to monitor if the tumor is shrinking because it gives the best visual of the tumor volume.
Okay, that's the landscape. We know the anatomy. We know how to check it. Now let's move to section 2, the benign stuff. And here, Baily and Love introduces a concept that I think changes the whole mindset. ANDI.
ANDI. ADI. Aberrations of normal development and involution. This is a crucial conceptual shift.
It really is.
For a long time, doctors called benign lumps diseases, like fibrocystic disease. But the Cardiff Breast Clinic, which developed this concept, said, wait a minute, the breast is a dynamic organ. It changes throughout life. Most of these lumps are just hiccups in the normal life cycle.
It normalizes the condition. It's not a disease, it's an aberration of a normal process. The text breaks this down into 3 phases. Let's use the timeline anchor here because it makes it so much easier to remember what happens when.
Right. Let's walk through the timeline. Phase 1 is development.
Okay.
This is early reproductive life, say 15 to 25 years old. The lobules are forming, the stromal tissue is growing. If that process goes a little overboard, an aberration, you get fibroadenoma.
The classic breast mouse.
Exactly. It's called a mouse because it's so mobile. You touch it and it slips away under your finger. It's solid, well-defined, smooth, just an overgrowth of the normal bits.
And then phase 2?
Phase 2 is cycles. This is the mature reproductive period, roughly 25 to 40 years. The breast is reacting to hormonal fluctuations every single month.
Proliferate, regress.
Proliferate, regress. If that response is exaggerated, you get pain, nostalgia, and nodularity.
And finally, phase 3.
Involution. The breast is aging, shrinking, from 35 to 55 years. As the lobules shrink, sometimes they leave space behind, or ducts get blocked by debris. This leads to cysts and ductictasia.
So fibroadenoma is a development hiccup. Pain is a cyclical hiccup. Cysts are an age and involution hiccup. That is a really helpful framework.
It is.
It stops you from just memorizing lists of pathologies and helps you visualize the patient's age and stage.
It makes the pathology predictable based on the patient's age. If a 19-year-old walks in with a mobile lump, your brain should scream, development phase, fibroadenoma.
Right.
If a 48-year-old walks in with a sudden fluid-filled lump, your brain says, involution phase, cyst.
Let's zoom in on the fibroadenoma for a second. It's so common in young women. How do we manage it? Do we just take it out?
Not always. In the past, maybe. But now, if the woman is young, under 25, and ultrasound looks typical, you can just observe.
Really?
Yeah. You don't necessarily need to cut. It might stop growing or even shrink. But if she is over 25, or if it looks a bit atypical on the scan, you need a biopsy to be safe.
And there is a scary variant mentioned. The giant fibroadenoma.
Yes. Anything over 5 centimeters. These grow rapidly. They occur often in puberty. You usually have to remove those because they distort the breast and can create ulceration.
Now, what about pain? Nostalgia. This is a huge reason women come to the clinic. It causes a lot of anxiety.
A massive amount.
The text splits it into cyclical and non-cyclical.
Cyclical is the most common. It's linked to menstruation, usually the luteal phase, the second half of the cycle leading up to the period. It's usually bilateral, both breasts feeling heavy and sore. It stops when the period starts.
And the treatment isn't always drugs. In fact, drugs seem to be way down the list.
Absolutely. The first step is reassurance. The biggest fear women have with breast pain is this cancer?
Of course.
Once you do the triple assessment and tell them, no, this is normal hormonal change, that resolves the issue for about 70% of women. They can live with the pain if they know it's not killing them.
And for the other 30%?
Then you move to a good support, Brosmal mechanics. Then dietary changes, flaxseed is mentioned.
Flaxseed?
Really?
Yes, it contains phytoestrogens. The theory is they modulate the estrogen receptors. The evidence is mixed, but it's harmless. Evening primrose oil is another common one, rich in gamma-linolenic acid.
Right, GLA.
Though again, data's conflicting. If those fail, you try topical NSAIDs like diclofenac gel.
And systemic drugs.
Last resort. Things like tamoxifen or danazol are a last resort. Because the side effects, hot flashes, clotting risks, are significant. You don't use a sledgehammer to crack a nut.
What about non-cyclical pain, pain that doesn't follow the calendar?
That's often anatomical. It might be a specific spot. You have to rule out things that aren't the breast at all.
Like what?
TT syndrome is a classic one inflammation of the costochondral junction, where the ribs meet the breastbone, or referred pain from the back.
So it feels like breast pain, but it isn't.
Exactly. The text mentions a breast pain chart.
It's an essential tool. You give the patient a chart to track their pain for a month. It tells you instantly if the pain is cyclical or not. Patients often can't recall the pattern accurately, but the chart doesn't lie. You can't diagnose properly without it.
Okay, I want to do a quick check-in here. Listener, pause for a second. Can you define ANDI? If you are still thinking of a fibroadenoma as a tumor rather than a developmental aberration, rewind and listen to that 3 phases explanation again. It's the key to understanding benign breast disease.
It really is. It frames everything as a spectrum of normal rather than a binary of sick versus healthy.
Moving on, section 3, inflammation and the nipple. Let's try a case study here to illustrate the text because these presentations are distinct.
Let's do it.
Okay. Picture a middle-aged woman. She's a heavy smoker. She comes in with a painful lump behind the nipple, a subareolar abscess. Maybe the nipple looks retracted, like a slit.
The classic fish mouth retraction. That's a buzzword.
Right. You treat the infection with antibiotics, drain the pus, but it comes back. And back again. Recurrent abscesses. What is going on here?
This is periductal mastitis. And the smoking is the smoking gun, literally. The toxins in cigarette smoke concentrate in the breast secretions. They damage the ductal lining, causing inflammation, necrosis, and subsequent infection. It's a chronic inflammatory process, not just a simple bacterial hit.
And because it's chronic and structural, the ducts are damaged. Simple antibiotics often fail.
Exactly. You might drain the abscess, give antibiotics, but the damaged duct is still there. It recurs. The definitive treatment for persistent cases is surgery Hadfield's operation, where you physically excise the major ducts behind the nipple.
But there is a kicker.
The kicker is if the patient doesn't stop smoking, the wound healing is poor and recurrence rates are still high.
Then there is the other side of the coin, lactational mastitis. A breastfeeding mom with a red-hot, painful breast. The old advice, maybe from a grandmother, might have been to stop feeding on that side.
And that is dangerous advice. The text is clear. Do not stop breastfeeding.
Why not?
The cause is milk stasis blocked, milk plus bacteria entering a crack in the nipple. If you stop feeding, the stasis gets worse, the bacteria multiply, and you get an abscess.
You need to drain the breast.
You need to drain the breast, keep feeding, or pump.
What if it turns into an abscess despite that?
Ideally, you aspirate it with a needle under ultrasound guidance. You try to avoid making an incision.
Cutting it open.
Right, because that leaves a scar and can cause a milk fistula leak that won't heal. Needle aspiration is the way to go, sometimes repeated every few days.
There is a brief mention of tuberculosis of the breast.
Rare in the West, but highly relevant in developing nations or immigrant populations.
And the sign.
It presents with multiple draining sinuses and a bluish discoloration of the skin. If you see a chronic abscess with blue skin, think TB.
Now, nipple discharge. This freaks patients out. They see fluid and think cancer immediately. But we have a rule of thumb, the 4S rule for pathological discharge.
Right. Most discharge is benign, but you worry if the discharge is
1,
single duct,
2,
serous or bloody.
3.
Spontaneous, so it comes out without squeezing.
And 4.
Sanguineous, which just means bloody again, but helps the mnemonic.
And colors matter. If a patient describes green or black or toothpaste discharge.
That's usually duct ectasia. That's the involution phase we talked about. Harmless debris and dilated ducts.
Bloody discharge from a single duct.
That's the worry. The most common cause is a duct papilloma, a benign, warty growth inside the duct that bleeds. But it can be cancer. You have to investigate with cytology and imaging.
And one more nipple issue, Paget's disease.
This is an eczema-like erosion of the nipple. It looks like a red, crusty skin rash. But here is the warning. If eczema of the nipple doesn't heal with steroid creams, or if it destroys the nipple, you must biopsy it.
Why?
It is often a sign of underlying DCIS, ductal carcinoma in situ, traveling up the ducts to the skin. The rash is just the tip of the iceberg.
Okay, taking a breath. We have covered the benign landscape. Now we have to face the enemy. Section 4, carcinoma.
The big top.
Epidemiology first. Most common cancer in women, 1 in 9 in Western Europe. It's ubiquitous. What about risk factors? The text lays out a balance sheet of risk.
You have the things you can't change. Being female, 99% of cases,
Yeah.
getting older, and genetics, BRCA1 and BRCA2.
Right.
Also, your hormonal history, early menarche, so starting periods young, or late menopause, means more years of estrogen exposure, which increases risk.
The breast is marinated in estrogen for longer.
Exactly. And the modifiable ones, this is where public health comes in.
Yeah.
Obesity, particularly postmenopausal. Fat cells produce estrogen. Alcohol intake is linearly associated with risk. And lack of breastfeeding. Breastfeeding is protective. It gives the breast a rest for the menstrual cycles.
Let's get into the pathology. The text distinguishes between in situ and invasive. This is a critical distinction for prognosis.
Imagine a house. The house is the duct. The basement membrane is the walls of the house. DCIS, ductal carcinoma in situ, is like a party that has gotten out of control, but everyone is still inside the house. The cells are malignant, they look like cancer, but they haven't breached the wall.
So it's contained.
It's contained. It's pre-invasive. It cannot metastasize yet because it can't reach the blood or lymph vessels outside the wall.
And invasive carcinoma.
They have smashed through the wall and are running into the street, which is the surrounding stroma.
And once they're in the street, they can get to the highway, the lymphatics.
Exactly. Most invasive cancers are ductal, 90%. A smaller number are lobular, 10%.
And lobular is tricky.
Lobular cancers are tricky. They don't form lumps as often. They infiltrate in single files like an Indian file pattern. They're harder to detect on mammograms.
Now, in the modern era, we don't just look at the shape of the cells. We look at their personality, the molecular subtypes. This determines treatment more than almost anything else now.
This is crucial. Breast cancer isn't one disease. It's a family of diseases.
Okay, let's go through them.
Luminal A. These are the lazy cancers. They are ERPR positive, meaning they feed on hormones, but they grow slowly. They have low Chi-67.
And the best prognosis.
They have the best prognosis.
Yeah.
Luminal B, also hormone positive, they grow faster, more aggressive.
Okay.
HER2 enriched. These overexpress the HER2 protein receptor. They used to be very aggressive killers.
Used to be.
Used to be. But now we have targeted drugs like trastuzumab that specifically shut them down.
And finally, the tough one.
Triple negative or basal. They don't have estrogen receptors, progesterone receptors, or HER2. They are triple negative.
So no target.
No target. They're the hardest to treat because we don't have a specific lock and key. We have to use dumb bombs, chemotherapy.
We need to cover staging. The T&M system, it's classic exam fodder, but also the universal language of oncologists.
T is for tumor size. T1 is small, under 2 centimeters. T2 is medium, to 5 centimeters. T3 is large, over 5 centimeters.
And T4?
T4 is the bad one. It involves the skin or chest wall. And a special note, peau d'orange, orange peel skin.
Yep.
This is caused by cancer, blocking the lymphatic drainage of the skin, causing edema. The hair follicles are tethered, so the swollen skin pits like an orange peel. This is T4D, inflammatory carcinoma. It is very aggressive.
It is for nodes.
N1 is mobile nodes in the axilla. N2 is fixed or matted nodes. They are stuck to each other or other structures.
Which is a worse sign.
Much worse. And N3 is when it spreads way up to the clavicle, infraclavicular, supraclavicular, or internal mammary nodes. N3 implies significant spread.
And M is for metastasis. Where does breast cancer go?
It loves bone,
Yeah.
especially the lumbar vertebrae and femur. It causes pathological fractures. Then lungs, liver, and brain.
Okay, we know what it is. We know how to stage it. Now, Section 5, the arsenal. How do we treat it?
It starts with the MDT, the multidisciplinary team.
Right.
Surgeon, oncologist, radiologist, pathologist, no one works alone anymore. The days of the cowboy surgeon deciding everything are gone,
Surgery has evolved a lot. We used to do the Halsted radical mastectomy.
which was a mutilating operation. They took the breast, the lymph nodes, and the pectoralis major and minor muscles. It left women with a hollow chest wall and significant weakness.
So what's next?
Then we moved to the MRM, modified radical mastectomy, which preserves the muscles. Much better. But now, the standard for many is BCS, breast conservation surgery, or lumpectomy.
But there is a rule for BCS. You can't just take the lump and walk away.
You cannot. You must get clear margins, so no cancer cells at the edge. A&ED, you must follow it with radiotherapy.
BCS plus radiotherapy equals.
Survival rates equivalent to mastectomy. That's the magic formula. If you can't give radiotherapy, or if the tumor is too big relative to the breast, you have to do a mastectomy.
What if taking the lump leaves a dent?
That's where oncoplasty comes in. It's the marriage of oncology and plastic surgery.
Okay.
If you have a small defect, you do volume displacement.
Mm.
You just rearrange the breast tissue internally to fill the gap.
And a large
A
defect.
volume replacement, you bring in tissue from the back, the latissimus dorsi flap, or elsewhere to fill the hole.
Let's talk about the axilla again. We used to clear all the nodes for everyone, just strip the axilla out, but that caused lymphedema.
Horrible lymphedema, swollen arms in a lot of women. Now we use the sentinel node biopsy.
Explain how that works.
Think of the sentinel node as the canary in the coal mine. It is the very first node that drains the tumor.
The first stop on the highway.
Exactly. We inject blue dye, or a radioisotope, into the tumor area.
Mm-hmm.
We wait a bit. Then we open the axilla and look for the blue node or the hot node with a Geiger counter.
And you take just that one out.
We take just that node out, or maybe a couple. If that node is cancer-free, we can be 95% sure the rest are free. We leave the rest alone. This spares the patient from lymphedema. It's a huge quality of life improvement.
Moving to systemic therapy. Chemo. Traditionally, we did surgery first, then chemo. Now, often we do it in reverse. Neoadjuvant chemo, NACT.
Yes. There are two main reasons to give chemo before surgery.
What are they?
One, to downsize the tumor. Maybe you can shrink a large tumor enough to save the breast. You turn a mastectomy patient into a lumpectomy patient.
And two,
to see if the drugs work. If you cut the tumor out first, you never know if the chemo you give later is actually killing the microscopic cells. If you give it while the tumor is there, you can monitor the response in real time.
And we have targeted therapies.
Trastuzumab, or Herceptin, for HER2 plus cancers. It changed the game. HER2 plus used to have the worst prognosis. Now it has one of the best because the drug is so effective.
Hormonal therapy.
For hormone-positive cancers, we starve them of fuel. Tamoxifen for premenopausal women, which blocks the receptor. Aromatase inhibitors for postmenopausal women, which stops the production of estrogen in fat.
And finally, reconstruction. If a woman loses her breast, we can rebuild it.
Either with implants or autologous tissue, which is her own body. The gold standard for autologous is the DIEP flap, using the tummy tuck tissue, the skin and fat, but sparing the muscle. It feels the most natural and ages with the patient.
Okay. Check-in question 2. Let's pose a scenario to tie this together.
Go for it.
You have a patient with a 3-centimeter tumor, and the biopsy says it is HER2 positive. Why might the surgeon suggest chemotherapy before surgery?
Think back to what we just said. HER2 positive tumors respond very well to targeted drugs like Herceptin and chemo. By giving it first, you might shrink that 3-centimeter tumor down to nothing, a pathological complete response, allowing for much smaller surgery, and you get proof that the drugs are working. You've tested the enemy's weakness.
Excellent. We have covered the anatomy, the benign, the malignant, and the management.
It's a huge chapter, but if you stick to the structure anatomy, triple assessment, ANDI, and the staging management pillars, you can navigate almost any exam question.
So, to summarize, Chapter 58 isn't just about cutting. It emphasizes the shift towards conservative, biological-based treatment.
Less radical surgery, more precision medicine, the scalpel is becoming more refined, and the biology is becoming more dominant.
Which leads us to a final provocative thought. The text hints at the future. Liquid biopsies detecting circulating tumor DNA in the blood.
Yeah.
De-escalation of surgery.
It raises the question, are we moving toward a time when the scalpel becomes the secondary tool to the syringe?
Wow.
Will we eventually treat breast cancer without surgery at all in some cases? The check engine light of the TDLU might be detected in a blood test long before a lump ever forms, allowing us to intervene chemically rather than surgically.
Something to mull over. Here's your call to action. Don't just trust our voices. Open Baily and love Chapter 58.
Please do.
Look at the diagrams of the lymphatic drainage. Visualize that pectoralis minor gatekeeper. Look at the picture of peau d'orange. Solidify what you've heard.
Knowledge is only useful when it's applied. Go apply it.
Thanks for diving deep with us. We'll see you on the next one.